Welcome to AETCM, the emergency medicine channel. Today, let us discuss about macrophage activation syndrome, hemophagocytic lymphohistiocytic cytosis. Both are almost similar, but there are minor differences between these two things. But commonly known name is macrophage activation syndrome. Clinical features are mainly high-grade fever. Any patient who is having infection or inflammation, they can have high-grade fever. Hepatosplenomegaly, multiple lymphadenopathy, hemorrhagic manifestation like bleeding tendency, elevated PTNR, elevated APTT, low fibrinogen levels, and patient can have a similar picture like a sepsis. It's a life-threatening condition. Most of the patients become very bad once they develop macrophage activation syndrome. One of the common condition, common disease where the patient develops macrophage activation syndrome is systemic juvenile idiopathic arthritis, lupus erythematosus, that is SLE, adult onset Still's disease. These are the common rheumatological disorders where the patient develops macrophage activation syndrome. But there are a lot of other immune and inflammatory conditions. Some infections also can produce or trigger macrophage activation syndrome. This syndrome is characterized by uncontrolled proliferation of T lymphocytes, and from there well differentiated macrophages are forming. That macrophages produces severe cytokine overproduction and severe inflammatory response throughout the body. That is the main problem in macrophage activation syndrome. Macrophages are produced whenever there is an inflammation or infection in our body. Macrophages are produced because they can produce inflammation, but here it will become a dysregulated proliferation of these macrophages. So they are derived from, these macrophages are derived from circulating monocytes, and whenever there is an infection or foreign antigen, these macrophages are overproduced to kill or destroy these external antigens. But sometimes dysregulated production of these macrophages can produce macrophage activation syndrome. So these macrophages can phagocyte other cells and other organisms. That is a function of these macrophages. They kill or eat other cells or other organisms. But when it becomes dysregulated, it can destroy our own cells. That is macrophage activation syndrome. So here we can get pancytopenia, bone marrow is involved, liver is destroyed, liver insufficiency or acute liver failure can occur. Blood cell production can be reduced, platelet can be reduced, or coagulopathy can be formed, like PT-INR can be elevated, and it can even affect the nerves that produces neurological symptoms, neuropathies, spinal cord dysfunction, or CNS dysfunction. So macrophages produces all types of inflammatory activity in our body. Whenever there is an infection or foreign body attack like virus or bacteria, these macrophages are normally produced. But when there is a dysregulated macrophage production, that can lead to disseminated inflammation and cytokine storm. This is called as cytokine storm syndrome sometimes. Okay, so macrophage activation syndrome or cytokine storm, both are almost similar. So it's a hyperinflammatory syndrome or inflammatory dysregulation syndrome. Normally, whenever there is an inflammation, that inflammatory process is regulated by our body, but here it is completely not under control and it is in a dysregulated manner. Primary hemophagocytic lymphohistiocytosis, that is a primary disease without any other secondary disease. So that is a genetical disorder or inherited disorder. Whereas secondary hemophagocytic lymphohistiocytosis or this type of macrophage syndrome we have seen, that is mainly due to a secondary disease, like it can be due to SLE, or it can be due to juvenile rheumatoid arthritis, or it can even be due to secondary to malignancies. Here the immunological activation can be triggered by the disease itself, or it can be triggered by some other viral infection or bacterial infection. Another entity, that is drug reaction with eosinophilia and systemic symptom, DRUS syndrome, that also comes under HLH, but it has got a different clinical scenario, like patient can have even dermatological manifestation in that, but that also comes under this dysregulated immune reaction in our body. So it is mainly produced by, we already seen that it is a dysregulated or imbalance of the immune system. That is a main problem. There will be hyperstimulation of immune cells and hyperproduction of the macrophages that produces all type of dysregulated inflammatory mechanism. So one of the common condition which produces macrophage activation syndrome is systemic juvenile idiopathic arthritis and SLE. Kawasaki disease also you can get like this. Some other dermatomyositis also can get this type of disorder, but for any other diseases like inflammatory bowel disease, rheumatoid arthritis, many infections, infections can be a trigger for this. Patient may have a basic tendency to develop cytokine storm. So infections can produce acute like it can be a trigger for the disease, but there are other genetical disorders, genetical problems also can produce this one. Malignancy can produce sometimes this type of disorders, and autoimmune disorders, and many drugs also can sometimes trigger this type of condition. Now, patients can become acutely ill during this macrophage activation syndrome. They can have high fever, purpuric rashes all over the body, jaundice due to liver disease, bleeding tendencies due to elevated PTINR, APTT, seizures, coma. Skin rashes can be seen in many patients. Scaling of skin or complete discoloration can occur. Some patients can have pancytopenia, leukopenia, anemia, or thrombocytopenia. So all these things can be there. Liver enzymes can be elevated, LFT will be elevated, SGOT, SGPT will be elevated. High levels of triglycerides, lactic acidosis, that is very important. Triglycerides can be highly elevated in many of these patients. LDH can be elevated, maybe due to hemolysis itself or a part of disease. Low sodium levels can be there. Prolonged prothrombin time, PT, prolonged INR, prolonged APTT, and because of this low fibrinogen level. So DIC picture can be there. DIC means APTT, PT and APTT will be prolonged. Fibrinogen levels will be reduced. So that is DIC like picture. D dimer may be positive. Now, many of these patients can have flaring up of the basic disease like rheumatoid arthritis can be flare up, SLE can be flare up, patient can have pneumonia, or infection can be there, features of infection can be there. So many features of infections or inflammation or existing disease itself can flare up, and sometimes it may be due to side effects of some drugs, like DRUS syndrome can be a part of drug-induced reactions. Even Steven-Johnson syndrome also can produce all these features. Now, when we investigate a case of HLH or macrophage activation syndrome, we have to see the complete blood count. You can see WBC may be elevated or reduced. Platelet, mostly it will be reduced. Infection screen like you can see the CRP, and you can see the blood culture, chest X-ray, urine routine, urine culture, procalcitonin, all these things can be done. PTINR, APTT should be done. For renal function test, we can go for creatinine, urine. Ferritin levels will be always high. Very high ferritin levels always indicates always indicates severe inflammatory response. Ferritin is an inflammatory response marker. So more than 10,000 nanogram per ml is a classical finding in many of these macrophage activation syndrome. Hypertriglyceridemia in cholesterol, whenever we have any patient who is having acute inflammation, if ferritin is very high, always check for triglycerides. So triglycerides will be very, very high. So fasting triglyceride 260, more than 265. Interleukin 2 can be tested if there is facility for interleukin 2 testing. We can do that. Then high levels of interleukin 6, interleukin 2, all these things can be there. They are all are inflammatory marker like ferritin. More specific inflammatory markers are 2 and 6. Bone marrow aspiration may show numerous macrophages producing from the bone marrow. Now, diagnosis, macrophage activation syndrome can be characterized by presence of 5 of the following 8 diagnostic criteria. You can see here, fever can be there, pancytopenia or cytopenia of any 2 types of cell. Triglycerides are very high, hyperfibrinogenemia less than 100, ferritinemia, ferritin will be very high, you can see 10,000, 20,000 like that, but more than 500 itself can, you can think about a macrophage activation syndrome. Hemophagocytosis in the peripheral smear, elevated interleukin 2 receptors, elevated interleukin IL-6 also, decreased natural killer cell activity, and splenomegaly. So these are the common findings in the patients who is having macrophage activation syndrome. So criteria for MAS, we have already seen that laboratory criteria, platelet count can be low, STOT, STPT will be elevated, WBC count can be low, hypofibrinogenemia can be there. Clinical criteria, CNS dysfunction like irritability, disorientation, lethargy, headache, seizures, coma, hemorrhages like hemorrhagic features like purpura, easy bruising, mucosal bleeding, hepatosplenomegaly. All these things are clinical criteria for MAS. Now treatment, mostly we know that it's an immune mediated or immune dysregulation syndrome. So like any other immune mediated disease, we can give intravenous immunoglobulin, pulse steroids, or cyclosporin, or intrathecal methotrexate. All these things are immunomodulators, like you give in SLE or rheumatoid arthritis. There are different types of drugs, but the commonly available drug is methylprednisolone, that is a steroid. Methylprednisolone 1000 milligram you can give as a IV, or IVIG can be given. IVIG 2 mg per kg body weight we have to give. IVIG can be given. So there are newer drugs. Imapalumab can be given. That's an immune modulator that can be given with a dose of 1 milligram per kg as an intravenous infusion over 1 hour twice per week. Alternative drugs are alemtuzumab. So that's an alternative for this drug. It's an anti-CD52 drug. Tocilizumab is 10 milligram per kg. That is also available in our country. That can also be tried. Now we have discussed about one of the important inflammatory condition, like many patients who come to emergency room with severe sepsis like features. If you do sepsis markers like bacterial markers like procalcitonin may be negative, culture may be negative, so nothing will be there, but patient will have severe sepsis like features. If the triglycerides are very high, ferritin levels are very high, multi-organ dysfunction syndrome is there, then you have to think about macrophage activation syndrome. Here, it is not the infection that produces all this problem. That is infection-induced triggering of immune cells, and that produces large amount of macrophages. These macrophages produces inflammatory mediators in our body. That inflammatory mediators produces multi-organ dysfunction, because these inflammatory mediators can go and attack our own organs. That produces complete dysfunction of these organs. So multi-organ dysfunction due to non-infectious inflammation in our body. Even infections can trigger this inflammation, but it is not the direct effect of infection like sepsis. Unlike in sepsis, the infection is directly producing all problem, or bacteria is producing all problem. Here, the infection triggers the immune system. Immune system overreacts against that infection. That inflammatory mediators can sometimes go and attack our own organs, then produce multi-organ dysfunction, and mortality rate is very, very high in this type of patients. Thank you.